first speaker of this session. And the first speaker is Dr. Marina Erhola. She's MD, PhD. And she is the Assistant Director General and the head of the Division of Health and Social Services at the National Institute for Health and Welfare in Finland. The institute is a research and expert one organized into 4 divisions. Dr. Erhola has 15 years of experience in health management. Dr. Erhola, the floor is yours. Please come.
In such a short time, it's really nice to see so many participants here and so on. Also regards from Finland, from our ministers, my boss, Professor Pekka Puska, who was not able to come here, but also sent his greatest regards to everyone, especially to the country representatives with this interesting period of time you are now struggling with putting your new system together. In the presentation, I will cover a little bit the health systems governance in Europe, examples from Scandinavia, and just a little bit from UK, because I saw that there's another presentation from UK here. I will be talking about centralization and decentralization, because that is one of the corner things when you are planning for your new system. And then I will be talking about national government and Ministry of Health structures, as I was asked to do in the title. Then I will highlight a little bit on issues on management and leaderships, because actually it's people that matter. That's why we need to be talking about those also. It's difficult for me to see here, but I would like to remind you also, as was done yesterday several times, on the 5 pillars on planning for health in any country. In any country, the government needs to be thinking of these main pillars based on which the whole system will be then actually built upon. The ultimate goal we want to reach is, of course, health. We want to have health on equal basis for all of the citizens. To do that, we need to have quality and cost effectiveness and the pillars of financing, organization, delivery, regulation, and monitoring. So this means also that we can actually not copy any model from one country to another country. Rather, we need to build the systems in each country based on the principles and other social and political issues of the country. This is extremely important to remember. Also, it means that if any of these pillars collapses, the whole system will collapse. On the other hand, it means that from the very beginning, when we are starting to plan for the system, we need to remember that all these pillars are extremely important. And it's the government who is responsible for all of this. So why? Why health on equal basis? Why are we so keen on producing health on equal basis? Because this girl who looks sad and who looks sick and who looks a little bit troubled, she needs it. It's her basic right to have health. It's her basic right for good health, no matter whether she is poor, whether she lives in Finland or in Libya or wherever. She has the basic right to health. And it is the responsibilities of governments to work so that this girl who looks troubled who looks sick that she has access to health services and she gets what she needs. It's a bit difficult to see here because it's so dark. I cannot see. So, yeah. Yeah. Here. And next, this one. Okay. So I'm just briefly summarizing the systems we have currently in Europe. We can divide the European systems roughly to two categories. We can divide the so-called beverage systems, which for example of is the national health system in UK, the Nordic model of tax-based systems and integrated financing and provision. And the so-called Bismarck systems, which have earmarked tax for health services and clear separation of funder, purchaser and provider. And the providers there can be private or non-profit. However, this classification has become a little bit old-fashioned because in reality we have a variety of mixed systems in Europe also. This is another newer categorization by OECD, which categorizes the services by whether they rely on market mechanisms in service provision or whether they are mostly public provision and public insurance. All the Nordic countries are here in mostly public provision and public insurance, and there we have actually quite big differences between the countries, whether we have so-called gatekeeping system or non-gatekeeping system. The gatekeeping system means in a way that there is some kind of a gate before a patient can enter, for example, the secondary level services, or whether they can self-refer themselves or whether they cannot self-refer themselves. Remembering this categorization, I think, helps quite a lot while countries are planning for their services and the whole system. What kind of a system you want to introduce in Libya is, of course, of crucial importance. And as I said earlier, no other country example can be copied as such to this country. So it needs to be built, tailor-made, adapted to this interesting country itself. Examples from European countries can of course be used, and I'm coming from the Scandinavia, and we have the Scandinavian models which we think are working quite well in that part of the world, but we also have our challenges at the time being. But as we were asked from the very beginning to participate to some extent in this process of Libyan re-engineering of the system by WHO, which kindly asked us to build to show the Nordic examples, I would like to go now into a bit more details of the Nordic examples so you get more or less of understanding what are our systems there and how they work and what we think are the good points and what are the bad points in those systems. In the Nordic model, it's the public systems, either through ownership or requiring private actors to contract with public bodies. What is very clear in all Nordic countries is that equity of access is high up on political agenda. Equity of access. And at the same time, in all Nordic countries, we are facing actually some challenges at the time being on equity of access, especially on primary level of care, which also in our countries, in many of our countries, is struggling now with recruitment of staff and so forth. Our systems are predominantly tax-based financing, and what is unique is the decentralized responsibility for the provision of services. All Scandinavian countries are quite decentralized in terms of provision of the services. The founding principles in all Nordic countries is that health and medical services are aimed at assuring the entire population of good health and of care on equal terms. We have so-called universal systems. Care shall be provided with due respect for the equal worth of all people and the dignity of the individual, meaning no matter whether you are poor or rich, you have the same kind of access to the services. And this is one of the founding principles of all Nordic systems. And at the same time, we are also facing challenges nowadays with access to services, mainly to primary care. I think in all countries we have challenges. And then when we prioritize on the need for services. Priority shall be given to those who are in the greatest need of health and medical services. And this prioritization in our countries, as all over the world, is also, of course, quite challenging. In this table, which I'm not going into details, you just see the differences between the Nordic countries, how they have been organized. Earlier in April, when I was here, I had the opportunity to give a presentation of the Finnish history, how we developed our system. And at that stage, I was already mentioning that Finland has the most decentralized health system in the world. My boss, Professor Pekka Puska, used to say when I was saying that, Marina, you cannot say that because actually you don't know if somewhere in Africa or somewhere in the world there is a more decentralized system. And also he was saying that you don't have a reference on that. Then 1 year ago I was preparing for a lecture in Kazakhstan, and I was going through a lot of literature, and I found one article saying that Finland has the most decentralized system in the world. And nowadays I show this article to my boss, and he says, okay, now you can say that Finland has the most decentralized system in the world. But we know also now that we went too far with decentralization. We are far too decentralized at the time being. If we compare ourselves to our great friend, our neighboring country, Sweden, for example, they have at the time being about 20 or 18 county councils which are responsible for health services. We have at the time being 342 municipalities that are responsible for health services. That is far too many, and just these days we have a quite challenging political debate going on how to reform the system. In Sweden, there are 3 democratic levels. There is the state level, which focuses, of course, on foreign policy, public order, higher education, research, labor market, social insurance, and transfer payments. But healthcare lies on 20 councils. But also in these councils, there is not only healthcare, but there is also other regional development issues and support to cultural activities and public transportation. So to that extent, it is integrated in Sweden also. And then there is the service providers, which vary, and there's a variety of service providers. And the municipalities in Sweden, which are about 290 there also at the time being, they are responsible for social services, mainly elderly care, schools, special planning, and so on. In Finland, our welfare model is a little bit different than the other Nordic countries, and to some extent the same. We have very large and strong public sector. We are very much focused on universal rights, social protection, and services are not targeted for specific groups. For example, the poor, they are targeted for all. We have individual social security and taxation. It's based on legislative rights of the citizens or residents. The legislative rights of the citizens are very strong. They are also very strongly related to the access to services and so on. So the municipalities which provide for the services, actually in theory they have quite a lot of freedom what to provide, but in practical terms not, because the social rights of the citizens, the legislative rights of the citizens are so strong. Governance is extremely highly decentralized into municipalities, and we still have relatively high level of benefits. Here is another map of our country where you see that on top of these 336 municipalities, we have 20 hospital districts and 5 university hospital districts. These hospital districts have become very strong nowadays. They are administratively very strong if we compare them to the municipalities. It's up to the municipalities to provide for basic health and social services and up to the hospital districts to provide for secondary care services. And this has meant actually that we have a great imbalance between these services nowadays because the hospital districts became so strong. So our hospital care and secondary care is much stronger nowadays than the primary level of services, and this is not a good thing. This means trouble, and we are trying to reform this process significantly. All the municipalities belong to one or to the nearest hospital district. They are obliged to belong to one, and the hospital districts are managed by the boards, which have the representatives of the municipalities, but still it's very difficult to steer the hospital districts because they, in a way, start leading their own life. In this slide, I have an example of cooperation network of a municipality. And I want to be talking about this because it in a way highlights why it's so important that things are planned for all levels at the same time. It's quite difficult to define what is the task of Ministry of Health if we don't know what are the tasks of aerial management. And in this country, as I have got to understand to some extent, is at the time being extremely centralized. Everything is at the time being quite centralized, whereas in some other countries we have problems with extreme decentralization, as we have in Finland. Probably the ideal model would be there somewhere in between. But if we start here from the bottom, we see the municipality here, the core of a municipality. We see what their role is. It's basic healthcare, administration of the school sector, elementary, secondary school, special school teacher, adult education, rural affairs secretary, and so on. Then we go to the sub-region level, where we have the joint municipal authority for health and for vocational training also, and for some regional enterprise development support. And then we go to the region level, and we have the more specialized healthcare and so on. And then on top of this is the state and the Ministry of Health, the national institutes and so on, which then help planning for the aerial services. So this is one way of organizing things. This is the way we have in our country at the time being. And at the same time, in the last OECD economic surveys of Finland, it was very clearly stated that the decentralized structure of Finnish health system contributes to inefficiencies, the far too decentralized system. No problem with decentralization, but we went too far. And they also say that resources should be shifted from secondary care to primary care to enhance efficiency. So why I took this slide to show that in any country that is starting the process from beginning or rebuilding the process, it is clearly extremely important to allocate enough resources to the primary level of care. Prioritizing health promotion and non-institutional long-term care would improve health outcomes also, they stated to us. So now we are struggling how to take into consideration these OECD recommendations, which are actually correct. It's just politically quite challenging to make the changes at the time being. So the strengths of the Nordic model, I think these strengths are more or less of all Nordic countries. We have good population health. We have still universal coverage. We have relatively good resources, and we follow the democratic rules. The democratic rules can be clearly followed. Sometimes we think, okay, it's bureaucratic and it's difficult and all that, but nevertheless, the democratic rules work quite well. The challenge is what we have is that we are starting to have quite big geographical variations in economic and human resources, in production volumes, in accessibility to the services. Also in our countries, in rural areas, it's more difficult to get access to care and so on, and the quality of services. In Finland, we are starting to see inequity, not only in access to the health services, but also the health level of the population, depending what is your income level, and this is extremely alarming to our country. So disparities are on increase in my country, which is not good at all. On the other hand, local and regional autonomy and decision-making close to citizens is highly appreciated. It makes sense, it's highly appreciated, it's important, But to what extent that should be taken nowadays, we are under discussion of that. So the national government task in this kind of a system which we have, which is quite decentralized, are that it has to guarantee prerequisites for high quality services to all residents on equal terms. It means that it has some saying in economic resources. The municipalities in Finland, they can levy their own tax, so they are the main funders of the regional services, are the municipalities that tax their citizens. Only about 30% comes from the government. Human resources, what the national government can do, we can plan for human resources, we can plan for educational programs, we can plan for the number of doctors and so on. Also, we have all the regulatory issues related to salaries and working conditions and so on. And nowadays there is strong legislation on the patient's rights in which time a patient needs to get to service if they want, for example. Then we have a variety of things related to quality-related issues and so on. Equity and equality, patient rights and citizen rights. I think all the Nordic countries are quite good, quite strong on this. So
3 minutes.
How many?
3 minutes. Please.
Okay, so means and measures for national steering. Here, overall health and medical care policy, non-binding regulation, recommendation of national guidelines, monitoring and evaluation, and supervision. I'm not going into the details of the charts of organizational charts. I'm just showing some examples of Finland. I want to highlight on the national institutes, which we have all strong in our countries. Sweden, we have this kind of a system. In Sweden, they have 4 ministers. We have 2 ministers of health, and in Sweden, they have 4. One of them is really dealing with housing, though. Organizations under the Ministry of Health, they are important. We have the government agencies, state-owned companies, foundations, etc. The government agencies, their roles need to be defined very clearly. They should be relatively independent, but they should not be too independent, and it needs to be planned how the government funding will go to the institutes. We have, based on our experience, we say that the government agencies, they should have quite clearly clarified their main tasks and responsibilities, including degrees of freedom. They should be quite simply structured, the development and evaluation preferably to different agencies. And in Sweden, there is now a great reform going on. They are proposing to decrease the number of agencies from 12 to 4. Just one picture from NHS in England, and the main message of this picture is in the center. I think UK has managed extremely well to put the patient in the center of the system. I think to that extent, UK is one of the best in the world. It's all planned so that patient is in the center, and in Nordic countries, we in a way envy this. So, management matters because people matter. No matter what kind of structures or boxes we have, management matters because people matter. In health management, we help other people via people. So management is so crucial. Adaptation of the system into country realities is also crucial. No system from another country can be copied to another country. National ownership matters because no one else can do it. No one else can do it. It's only the country who can do it. It's only the Libyans who can plan the Libyan system. No one else from abroad can come and do it. It's you who can do it. And first we need to know where we are coming from, and then we need to know where we aim to go. And the rest is actually quite simple. Management is wise use of resources with careful consideration to obtain the defined goals. Goals are important. And we tend to do things often very complicated, like this Finnish man. He wanted to go to the lake, and he could have just gone via the stairs, but no, he decided to do this kind of a very complicated procedure, which is risky also. And the same matters to management, I think, also. Often we just miss the very simple solution. We tend to make things complicated. No need for that. We can do things simply. We just go to the water, even if it's cold, and start swimming. And I think you can do that here in Libya also. Thank you very much.
Thank you, Dr. Erhola, for presenting the Nordic model and to give some important concepts under health systems governance. Now we have left with 5 minutes, and we will open the floor for discussions for few burning questions, please. Do we have a portable mic to the audience or no? And please, lights on.
Libya, we know it's an estimate rate about 30% of Libyans are unemployed. This is a very vague figure, and I'm sure it's more than 30%. But also, being a Libyan, I know every Libyan goes to the private sector and buy medications, and also, spending lots of money on them. So, because this Nordic system is based on tax, it won't work for Libya unless the unemployment rate is reduced to almost at least 3% like in Europe. Sorry, thank you very much.
Yeah. As I said, every country needs to plan for their own system. However, we have an experience of Finland who went to very, very difficult economic depression in the 90s. We were in the worst economic depression there has been in Europe after the war we faced in the 90s. Our unemployment rate rose up to 22, I think it was for a certain period of time. And we managed, but it was very, very difficult time. I was not suggesting that you should take exactly, as I said, the Nordic system, but some parts of centralization, decentralization, personally I think that those are actually the issues for Libya to plan the whole system. What is the role of aerial management? What is the role of the national government and Ministry of Health? And these were just examples for your consideration.
We will have time for 2 additional questions. Dr. Rida, please.
Thank you, Dr. Hora. You just highlighted how the British have succeeded in putting the patient in the center of the health system. Can you please expand on this and how to do it? I think because this is what we really need in Libya. Thank you.
I think actually we have the representatives from UK here who can actually do it better. But when I was visiting and seeing the UK system, I came back home from UK very, very enthusiastic because I could see that actually they defined quality of care a little bit differently than we do in Finland, because they have a 4th component on quality of care, which was the experience of the patient of the services. In our countries, we don't have that. And that really puts, the patient into, because it is one part of how the system is financed and all that, how the patient feels the experience is and so on. So I think the UK representatives will be better to answer on this, because this is really what you have done extremely well in the country.
Okay, Dr. Awad, but very quickly, please.
Okay, thank you very much for the presentation. I want to reflect on the point raised by our colleague regarding the tax base and the unemployment. He has rightly made the point that if unemployment is high, then we should not consider asking people to pay for taxes, especially if we are putting more burden on the industry and more burden on the production sector. But the point is that in Finland, they are using taxes because this is the source of funds of the government. In the case of Libya, there are other sources of funds for the government. And the main point is to use the general government revenue. In the case of Libya, it's the oil revenue. Rather than considering shifting for a new system, you can rely on this oil revenue to fund your health system. It is very similar to the tax base, but it's coming from a different source of funding for the government. Thank you.
Thank you. We will still have one only quick question and then over.
Well, thank you for Dr. Rala for the nice presentation, a detailed one. Just my question is the distribution of allocation of resources and finance through the municipalities and regions of Newfoundland, for instance. How much those resources and finance allocated to municipalities or regions, and how much a say they have in spreading those resources and finance, and is there any third party like controlling the funding of the Ministry of Health? If you can, just in a few minutes, if you have the time to elaborate.
Yeah, we can also go into detailed discussions with you after this, but The municipalities and the regions, they pay for about 60% of overall cost. The proportion of Ministry of Health or the government is to 20 to 30%. It depends a little bit, and on household about 10%. So the municipalities and the regions, they budget themselves, they plan for their services themselves. They are totally autonomous to do it. But on the other hand, it's the legislation that binds them very, very strictly, because the patients have the rights. So they have to organize the services so that they are following the legislation on the patient's rights, for example, to access to the services. So in reality, there is not that much freedom, but in theory, they can do it as they want.
Thank you, Dr. Erhola, and then we move to the second presentation, please.
Okay, before just Dr. Forti is going to introduce the second speaker, just want to say something. I think all of you have received the conference bag. There are 2 tickets inside the bag, which is for the lunch and dinner. You're not going to have them without those tickets. So please keep them for the lunch and dinner later on. Thank you.
What makes a good MOH is the second paper, or the second lecture will be presented by Professor Hans Rosling. In fact, I have a lot to talk about Professor Rosling, but in brief, Hans Rosling is one of the international pioneers leading health services in the world. He is co-founder and chairman of Gapminders Foundation. Most important to us that his research focusing on economic development, agriculture, poverty, and health in Africa. Professor Hans is health advisor to WHO, UNICEF, several other agencies. Okay, Professor Hans, come please. Here, okay. Okay.
Thank you very much for giving me the opportunity to on this impossible title. And what is a good important thing is that the Ministry of Health take care of its part so that there is no too much overlap and confusion with other ministries, and especially that there are not wide gaps which are not covered. So given this difficult task, I had to make a very simple cartoon out of this. Imagine that this is where people live. This is society. They are living their life up there. And here is a dangerous cliff with sharp stones down here. So wisely enough, there is a hospital built here. So if someone falls down and hurt themselves, they can get treated. Isn't that the most simple conceptual model you can have of a society and its health system? And indeed, it does happen that people fall down and hurt themselves like that. So now that person will go to the hospital. This is a bad Ministry of Health who thinks like that. That's not very advanced thinking, because everyone don't get so much hurt. And the main problem is that we get people to the hospital who doesn't have to go to the hospital. And we know it all over the world, this problem. We keep struggling and no one has solved it. You just have to minimize that. But you must have some sort of primary care. This must be primary care, you know, where it's a child who has fallen and they don't have to rush to the hospital. There should be health service, primary health service closer. And I haven't heard so much that it's not only physicians that are needed. Primary health care nurses can in many setups do wonderful work. And looking at the map of Libya with its vastness also, it's highly urbanized, but there are very many remote areas. How to organize this? Primary health care so that hospitals do what hospitals are needed for and not for other things. And it remains throughout my professional life, throughout my personal life in Sweden, it remains the main problem whether to rush to hospital or not when you get sick, and how you can handle it in primary health care. But of course, we don't only sit down there in the health service and wait for people to fall. We could build a fence up there. Isn't that a good idea? So that people could go to this cliff, they could see the beautiful view and enjoy it, but they doesn't fall down. This is vaccine, isn't it? This is a safety belt. This is nutritious food. This is all those things by which we can prevent disease. Who is in charge of putting that fence? Is the fencing up there, is that the task of the Ministry of Health, or is the Ministry of Health only waiting for people to crash their head down here on the cliff and then they take care of them? It's a definition of who takes care of this, which is enormously important. Our neighbors said that we had 4 ministers of health of Sweden. Well, we usually say 2. We have one minister of health who is in charge of things down here, and we have another minister of health who is in charge up there. But that's on the political level. On the administrative, civil servants level, it's even more complicated. And you have to think about, on your regional levels and in your national structure, who takes care of what. I was happy yesterday to hear that actions are really already being taken to secure traffic safety in Libya and improve that. But it's very important that you have clearly, so who is in charge up there, who is in charge down there. Now the people up there will measure their success with the statistics coming from down here. So it's very important that the statistics and the data coming out here is not only on how to manage the primary health care and the hospital service, but it's also to measure what is happening up there. And of course, it's not enough to prevent and to treat. You also need rehabilitation so that people who have been hurt, they can come back to their society and live up here. Quite nice. I did it in PowerPoint this morning. So rehabilitation is in many aspects a separate thing. It can be extremely costly. It can be extremely costly. It can even be wasteful. And it can be terrible if you forget it. So it also takes its own skill. But what's mainly needed is that we have health promotion up here, that we have a good society. We just heard the terrible unemployment rate in young men or young women here. If you can reduce that, it's perhaps the best things you can do for health. Because a young person who is unemployed will drive carelessness, will not be careful in traffic, will smoke, whatever. You can't discuss health promotion with a person who is 22 years old and is unemployed. So bringing down unemployment could be the absolutely most important. And that is neither this Minister of Health of curative care or preventive. It's really how the whole society operates. Now, this is what I tried in a more boring way to show yesterday, that you have rehabilitation, you have all these different functions, which are not so clearly defined. When we come concretely, especially when we translate them from English to our own language. I discussed with my Finnish colleague this morning on how difficult we have in the Swedish language to distinguish care and hospital service, because people have a very clear idea what it means. So I think you have a very important effort in this time of change to define it in Arabic and in Libyan Arabic. In Libyan Arabic, what you mean with the different things. And I would say healthcare here. And I hear in this conference that you talk about healthcare as if it's the health system. But you have to add these two things because they what pays off most. These two is what is more important for health generally than this. And if we would look and how you would organize your public health, it's a real big challenge, and that's very much cultural. For instance, in our country, we have infectious disease control completely separate from other aspects of public health. And you still need to work on infectious disease control. Well, everyone needs to continue to have that very sharp, but you still have tuberculosis. As all countries who rapidly come out of poverty, they carry the tuberculosis with them for another 2 to 3 decades. It's interesting to see Korea, South Korea, for instance, who have so good health indicators and everything, but they still have a lot of tuberculosis because they carry it with them, and it takes 50 years to get down tuberculosis frequencies to really low level. Now, how do you organize that? Let me remind you about this relation. The income of countries here, $1,000, $10,000, and $100,000 in purchasing power parity. I should explain the difference between purchasing power parity and market exchange rate, because to me, those are the main confusions when we discuss cost of health service. Market exchange rate is what we get when we go to the bank and we change our money. And we get another currency, we go to that country and we say, wow, how cheap it was, or wow, how costly it was. Purchasing power parity, that's what you get for your money in your own country, so that you can compare between countries. But that's very tricky when we compare health service, because one aspect of health service is indeed what we buy in our own country. We build the facilities and we employ the staff. But when we import drugs, machinery, or hire foreign specialists, then we pay in market exchange rate. So it becomes difficult to compare. But we have countries in the world who live far below 1,000, and then we have countries who are on $40,000, $60,000 here. And can you see, there's no division in Western and developing world. It's gone. It's a myth. There are countries on all levels, and especially they are clustered somewhere in the middle here, with China here. Now this is 2006 data only. If I would be now, China is even advanced here, and Russia, Brazil, and Argentina, and most of the Middle East you have there. This is more or less where Libya is. And the typical thing, as I told you yesterday, is here that if I pick Sweden there, we have $33,000 in total, and we use $3,000 for health service, or the health system. That's 10%. And Norway, and it's painful for us that our little brother now is richer than we, but we have to accept it and we have to be polite, you know. So they are 50% richer than us, and they have 48,000 and use 4,500. Can you see it's the same relation? It's the same relation, but they have much more money for health service than we have, just because they are richer, not because they use a higher percentage. I really want to emphasize that, because that's not often said. And then you come down to, that was Lebanon, let me see, wasn't Libya there, which has a much lower. But here I would be careful. Remember yesterday I said, don't trust all data, don't disregard all data. I think it's very important that you go back and see how has it been calculated. When Japan comes out with a very low health system cost here, it's often that they handle their geriatric care and the care for old people in a very special way, which is culturally based to a large extent. So there is difficulties comparing. What is best is probably comparing to your neighboring country with same age structure, with similar cultural and organizational history. Then it makes more sense. But it's very clear that the political difference is not so big. You would think that those who make high priority in a social way and in a government way would have much money on health service, and the other would have little. We use as much as we can for health service, more or less. But if you go down here and you look at countries like Ethiopia, there is absolutely no 10%. It's 3 or 4%. And to me, it's very natural. When you have a very small income, you can't use 10% for a health system, because you need food, you need water, you need school, you need shoes, you need houses. The richer you are, the higher proportion you can use. But that doesn't defend that United States of America use 15% of its GDP per capita for health service. So it's interesting that here it's 15% and Norway, which is richer, use less. And they get a better result. So it's different between countries. I think this is interesting. Now there are some other charts which can be even more interesting when you compare. Look at this one. This is out-of-pocket payment. Now we are in the health care. How much of the health care is paid by the sick patient taking up the money and paying at that spot when they are sick? It's varying very much. And the pattern is that the richer you get, the less you pay from your pocket. Isn't this world unjust? The richer you are, the higher proportion of the money you use for health service and less of it you pay for your pocket. And this is now where Libya on this one, according to the data existing, see Libya is out halfway. And we heard today that, yes, Libyans use a lot of their money to pay for the health service. That is not the future. No country has done that except for this outlier here, Singapore. But that's not true, really. It's just a technicality because it's compulsory saving by the government. The government takes money without a choice for the family and put it into account where there's only one door out, and that door goes to health service. And there's no way the individual can take that money and buy a boat for it or buy a vacation tickets for it. It's locked up there. So it's really like a health insurance system. And it's interesting to see here that United States do not have an especially high out-of-pocket payment because people have insurance, and it's the insurance that pays for this high health system cost per capita. So actually you will find Norway here have higher out-of-pocket payment than the United States of America, though they have less health spending than the United States of America. And that's even in Sweden. We have fees, and the same in Finland. We have fees on a lot of things, but those fees are mainly regulatory. That's to regulate the flow. So it costs somewhere when you go there. And we have tried in Sweden to have higher fees if you come to the emergency department at the hospital and you are not sick till you get admitted. If you get admitted, you pay nothing. If you don't get admitted, you go home, you pay more than if you go to the primary health care. It didn't work that well. People got angry and voted for another party next election. So it's very tricky to deal with voters. But this is important to say that just because Libya have still quite high out-of-pocket payment, no one do like that. The ones who have less money than you, they have even more. And those who have more, they have less, whether they have chosen one or the other health system solution. Thou shalt not have the sick pay for health service. The healthy must help to pay for the sick. This is how it works. And that's the principle for fair taxation, and that's the principle for a functioning commercial insurance system. It's the same. Then whether the rich should pay for the poor, that's more political. But that the healthy has to pay for the sick, that's very clear. Now, a third graph here. I put life expectancy here. 50 years, 60 years, 70, healthy, sick. And then I put the total health spending per person here. $10, $100, $1,000. Remember, it's about 1/10, so it's less there. And you can see that there's a very clear relation in the beginning, and then it's a less strong relation. And as they say in the competition, and the winner is Japan. So it's neutral. Japan is not represented here, is it? No, so that's good. It's a neutral. And they get really long life with relatively low health spending. Is that because their health system is so efficient? No, it's public health. It's outside. It's their diet. It's that women in Japan, they don't smoke, they don't drink. Yet they are picking up. They are picking up. But it's very much outside the health system. And you can see even South Korea is doing better than the United States here. So when it comes here, but it is indeed another step down here. And I showed you yesterday, these are the main public health issues like traffic safety, like smoking, like a lot of these things and how you organize society that can be so amazingly different. Now you're welcome to use this at Gapminder's site. We have collected about 600 different indicators here. So if you go to infrastructure and you go to traffic and you find traffic takes for 100,000, and it's very quick to change this around, and you can see the traffic deaths here. Now, I think this is the sort of analysis you have to do in your country. You have to realize that The health status of the people in the future is how you deal with life, how you deal with traffic, how you deal with unemployment, the general success of the country. And one of the major tasks for the health system and the Ministry of Health is to feed back that information into the society through the media and education, to feed it back into the government for priorities, but cannot act on it. Health service cannot employ everyone to cut down unemployment rate. Then you have to run the system as efficient as possible, but others are better to advise on that than we are. That, at least remember that public health is part of the health system. This is sort of difficult. Danger, if you're falling off the cliff, will cause injury and death. Stay back from cliff edges. People don't like health education. It's really challenging how you deliver health education. Huh? I mean, in Sweden, we tried to have people to eat less fat and more bread. So there was a classical announcement about 25 years old that you should eat 6 to 8 slices of bread per day. And that became a hate symbol for the government influencing individuals on how to live. It became a joke. 6 to 8 in Sweden has a meaning in the language. And it's one of my friends who coined that one in an attempt to do health promotion. Many countries, the TV series is a very good place for health promotion. To really run TV series. If you can get traffic safety into the soap operas in TV, that can work very well. And that shows how far away it is from the health system where you can impact this. But this is really your public health challenge number one. After my lecture yesterday, I had many young Libyans laughing at me and saying, oh, it's impossible. Libyans will always continue to drive like this. I had about 20 persons who said that last night. And I said that you can never stop Libyans from smoking. Oh, that's impossible. It's exactly what I heard in my country 30 to 40 years ago. Let me just end with one thing. If you could take away Gaddafi, you can take away this. Good luck.
Okay, thank you very much, Professor. We have 5 minutes for discussion, please.
For your nice presentation, I want to from you that to advise the policy maker in Libya to follow the approach or strategy of primary health care to strengthen the health system in Libya. Thanks.
And it's also primary health care will function well if hospital functions well. Because if primary health care can't send away the patients who need hospital, they will get bad reputation. And primary health care will work better if you have health promotion. So it is having balance over the whole system that also will facilitate for each aspect of it to work better. And hospital will work much better if primary health care works well, because they will then function well. So it's very important not to pay doctors in hospital per person seen, because then they will rob the easy patients from the primary health care and run them in the hospital. We have found that it's quite useful to have fixed monthly salaries for doctors in hospital, and they should be relatively good. Then they will make better judgment on each patient. But it's still difficult to have them to work well. They are tricky. They go away and do some research. They have some seminars. They go to interesting international conferences. It's very difficult to manage medical doctors. Let's face it. It's very difficult to manage medical doctors. They are very tricky and they have their ways, you know, especially when they get senior and they are really useful.
Tack så mycket för jättebra presentation. الهادي براوي في جامعة الإمارات. I'm from Imarat, and I was in Sweden for 10 years. I worked in Lund University Hospital as pediatric cardiologist. My question is that we need in our country, and I need your...
We don't...
yeah. I need in our in our country we need to concentrate. In our country we need to concentrate on the prevention, as you suggested already, which mostly the cardiovascular problems, and we have also a high sort of percentage of people with heart attacks.
Yep.
Plus, of course, as you already said, regarding the accidents and other problems. So what do you think yourself that how we can sort of put things together and concentrate and make the public health issue, especially for one of them actually saying cardiovascular problems in Libya? What's your opinion?
To me, no, education is, this is not very funny. Someone put a poster, do this, do that, do that. It's very difficult to get that to function. You can scare people, it's not so effective either. It's a culture. It's a culture. Taken, if you accept an example which may be special for my culture, but one of the most successful fight against smoking in Sweden was who want to kiss a smoker? It's like when it becomes culture, you know, and when this sort of behavior is not good any longer. With motorbikes, we had a tremendous problem. Like Libya, Sweden has vast distances, where young men on motorbike, they want to ride fast with their motorbikes. And there was an organization with a motorbike association on smart driving, where they could get the gold helmet, you know, and they could cruise. And we used the spinal cord injury group who worked together, because most of young men with spinal cord injury are motorbike accidents. And they would work together on smart driving instead of fast driving. And they had a special sort of diploma they could go if they on a very tricky road could manage their motorbike. I think it has to transcend the health system. It has to really become culture, that this is the way you do. Every country have a problem with its climate. Sweden are dreaming of having a Libyan climate, and many days you are dreaming of having a Swedish climate because it's too hot here. We always want it differently. Now, this climate is difficult for physical exercise. You need to have physical exercise early in the morning or in the evening, when it in cities may not be safe or socially acceptable that you are out walking. How do you solve that? How do you create a culture of physical exercise which fits your modern thinking of sport and family life, and which fits your culture and your other values? That has to be respected, but there is no way you can avoid overweight and unhealth if you don't enable people to have a physical exercise. And I would say it's especially for women, so that they are free to exercise. And don't think upper class playing tennis or something like that. It has to be for everyone. How do you recreate that? In our countries, creating possibility to go by bike to work was very, very efficient. But it's once more, it's special in each country. But really, to me, it's not education only. It is that creative way of having a healthy life. People must like to live up there, not go to the cliff. The enjoyment in their life shouldn't be to drive 145 kilometers per hour and smoke and just eat a lot. There must be other things which are more happy and which are valued in life. And I think that today people don't run in Sweden to stay healthy. They run in Sweden because it's been a way of life. And they do long distance running and so on, you know, and they have their Ethiopian idols who run so fast. So transcend it to culture, that people value a life that also is healthy, so that the health effect becomes a secondary effect of the activities. Then they will establish themselves.
Just because we are conscious about the time, the last two quick questions coming from Dr. Nabil and Dr. Bast.
Thank you, Professor, for a lovely presentation, as usual. My question is, the title of the lecture was what makes a good Minister of Health. We have a problem here. what is the job of the Minister of Health? Let alone a good Minister of Health in this country. I'm not talking about anywhere else. Now, anybody who is put in this challenging position in Libya, we got used to taking all the powers, everything. It's not only centralized. It's not centralized in Minister of Health. It's Ministry of Health. It's centralized in the Minister of Health. So, can you tell us what is the job of the Minister of Health in your country, for example? Thank you.
I think the answer to that question is more generally linked to the development of the state and development of the general government system. In our country, for instance, the Minister of Health is never, ever a medical doctor or a health specialist. It's a politician, a general politician, because the Minister of Health only have the overall laws and regulations and budgets. It's operated by civil servants, which are Director General of the National Board of Health and Social Welfare and of the different county administrations. So it's civil servants who operate it. In other countries, the Minister of Health is indeed the one who signs operational decisions in the system. But that's not special for health. That's our entire government system is like that. And that's quite special for Sweden. So it's difficult to have the Minister of Health to operate in any other way. We feel relatively comfortable with having the Minister of Health being a politician. That means that the whole system operates without the present government, and the Minister of Health will do the changes during those 4 years. Reform, work on one reform for the care of the elderly, how that will be, trying to cut the queue by one. But the whole system works its way, and it's civil servants who come with a proposal to which the minister will say yes or no. Then there is an ideological debate. But I will say that this is more, and as we said also, how will the country be managed from the nation, the province, the district? It's not just health service, it's the entire country, how it will be handled. And one problem we have seen there is that some things in why Finland and Sweden is more relevant to Libya than UK is that we have the same size of population. UK is a relatively big country. But we have this limited amount of people. Some specialized services has to be almost national. You can only have one center for that in the country, whereas others have to go down to primary health care. And that's very difficult to find the right level for each type of service. And that's not only for curative service, it's also for prevention. Sometimes people place too much of prevention in primary health care when you just need a good TV program to change the attitudes. So it's thinking about the level where you should act upon it. And the politician's main task is to create that function of the state, not to run it, I would say. That's also why I would say that under the past decade of a very strange and severe dictatorship, your people and your country were progressing in spite of that dictatorship in many areas. And that has to be recognized, that people got trained, people were more capable, families changed attitudes of it. And a final word then would be that having passed through such harsh times, there are two ways of looking upon it in relation to public health. One is, you have to sacrifice a little. You have to take some risk. When we were fighting our dictator, you know, young people risk their lives, so we can't be so fussy about traffic like those people in the Nordic countries, you know. The other is to do what I said. If we manage with Gaddafi, we can do anything in this country. We can do even these things. We can change this attitude. We can improve in that way. I've seen many countries who have gone through harsh periods which have difficulties handling with occupational safety, traffic safety, public health, because they had suffered so hardly and badly in the past. Don't make that suffering or that hardship continue in the way the country look upon health. But do it the other way. We did the impossible, and we can continue to do so.
Okay, and just please, the last very quick question.
Good morning. It's a comment rather than a question, and I wanted to use this opportunity to attract attention to it. In fact, I'm a pharmacist with a PhD in clinical pharmacy practice and another PhD in health promotion. Health promotion has been well recognized worldwide, and accordingly in the West and in the world they have established systems and to support healthy environments and health promotion. Here, we well agree on the importance of health promotion, which is the new term of public health, which includes health protection, disease prevention, and health education. But when we go to practice, we are totally against that. We are disease-oriented, and therefore it should be called the Ministry of Diseases, not the Ministry of Health, because when we practice, we do not support primary health care and health promotion. So it's an important issue that we need well to consider to give priority to public health, health promotion, and disease prevention to primary health care. Thank you.
Okay, I think the first session, which is the health system governance, come to the end. It's give me the opportunity again to thank the speakers for the wonderful talks, and to thank the chairpersons. And now we're going to hand it to the other chairpersons for the financing healthcare. Thank you very much.
Thank you very much. Thank you very much.
And a pleasure to be here in Tripoli at this international conference on laying the foundations for a health system in Libya. My Minister, Andrew Lansley, sends his best wishes for a successful conference. When he met with Minister Hamrouche in May, he offered UK support for this conference. So I'm delighted that we have a number of excellent speakers from the UK here today.
So we can't hear you.
Can you not? Is that better? Okay. When it comes to health, we have many challenges in common. People want to live longer, have healthier lives, and increasingly they expect modern and better healthcare. Yet this expectation challenges our ability to deliver practical changes to our healthcare system. Secondly, the cost of healthcare are rising. We all face the question of how to contain costs while improving quality. And thirdly, our populations, as we've seen today, are changing. More people are living longer, and this is a success. But success brings challenges. The needs of older people, especially when they become frail, are more complex, and we need to find new ways to provide care and support. Of course, we both face a mounting increase in the incidence of non-communicable diseases, such as type 2 diabetes, linked to modern life. Busy lives, stress, smoking, and convenience food, amongst other factors, all add to the burden of disease and illness, much of which is preventable. So, as well as shared challenges, we have shared aims: preventing ill health and providing high quality and affordable health care for all our people. By working together and exchanging ideas and practical solutions, I believe we can face these challenges with greater confidence and achieve our aims with greater success. When I was here in March, I was struck by the scale of the task you're grappling with as you work to rebuild your health system. Back in the UK, the NHS was also born out of conflict. 70 years ago, during the Second World War, a civil servant by the name of William Beveridge wrote a report that would change Britain forever. His report led in 1948 to the creation of our National Health Service. Today, it has an annual turnover of $165 billion, employs over 1 million people, and every 36 hours treats 1 million patients. But when the NHS began, there was little support when people became ill. They faced catastrophic costs in the event of serious illness, and the only way to see a doctor was to pay. For most people, healthcare was unaffordable. The solution, bold and ambitious, was the National Health Service, or the NHS. The values of the NHS have remained true for over 60 years, yet the service itself has to keep changing and adapting. Today, I would like to talk a little about the NHS, its values, its basic model, and about how it is changing to adapt to modern times. It's impossible to talk about the NHS without talking about its values, the principles upon which it's founded. More than a set of buildings, or people, the NHS is an idea. It's underpinned by a belief in fairness that all individuals are of equal significance. The NHS Constitution sets out our values: comprehensive health care, free at the point of need, and paid for through general taxation. Let me take each of these points in turn. First, the NHS is comprehensive. It meets a patient's clinical needs, whatever they may be. It also has a social duty to promote equality. Secondly, the NHS is free, based on need and not ability to pay. This was a huge decision by the British government at the time, but after the sacrifice of war, with the level of poverty that existed at the time, it was the right decision for the country getting back on its feet, and the public demanded nothing less. Third, it's paid for solely through general taxation. We are probably unique in this respect. There is no co-payment system for healthcare in the UK. Every member of society, rich and poor, contributes proportionately through tax, and the service is available according to clinical need. After 60 years of experience, we continue to believe that this is the most effective way for us to reach as many people as possible. But free healthcare isn't just an expensive gift, it's a hard-headed investment in the future. And we believe it provides exceptional value for money. We've seen a lot of figures today about percentage of GDP spent on healthcare. In the UK, last year, we spent 9.4% of UK GDP. Less on healthcare than most other European countries, and roughly half that of the United States. And yet we're able to offer comprehensive healthcare to the entire population. The knock-on savings to the economy are also significant. We've learnt that the benefit to society of a system that takes away the fear of getting sick. And we've learnt the benefit to our private sector, which is not weighed down by huge and growing medical insurance costs. British companies do contribute through their taxes, but the burden is shared across the whole of the taxpayer base, and not just the companies who choose to support their employees. We want to give individuals and business the ability and freedom to fulfill their own potential. The NHS helps them do this. So how does our system work in practice? In the first instance, it's focused very much on primary care. Local family doctors, general practitioners or GPs are the heart of the NHS. While not employees of the state, they are paid by the state according to a contract which is negotiated nationally between the government and representatives of GPs. Under this contract, the income of GPs is linked to the size of the population they serve. In recent years, we've introduced additional incentive payments linked to performance and to quality. For example, GPs can earn additional money if they meet targets for vaccinating children. GPs can also expand their income by widening the scope of the services they offer. Many employ community nurses, physiotherapists, and mental health counsellors. We keep these incentive payments under review so we can focus our GPs on new and emerging health challenges. In terms of hospital care, GPs act as gatekeepers, a vital role. If you're sick and it's not an emergency, the GP is your first port of call. For most people, the GP is able to provide sufficient treatment, advice, and medication for no further action to be taken. If not, they can refer the patient to the most appropriate specialist for expert advice and treatment. This provides a number of benefits. People can see the doctor when symptoms first present, not wait until they become an emergency. If a patient is referred by a GP to a hospital consultant, any follow-up can then be coordinated through the GP. In our experience, this approach helps to improve the overall effectiveness of care. Most people who use the NHS have several conditions. A patient with diabetes may also have a heart condition, mental health problems, arthritis, and no one specialist in the health system can take an overview of all their conditions, but their GP can. For us, therefore, general practice is a crucially important part of our healthcare system. GPs help to moderate and manage demands on hospitals and ensure that expert specialists focus on the patients with the greatest need. We continue to seek improvements to this system. Right now, we're looking to improve in 3 areas. We're looking to get GPs to do more to prevent illness and detect symptoms earlier. We need our GPs to take a broader role in coordinating care, ensuring the person is seen in a holistic way, recognizing social needs as well as health needs. And from next April, we'll be asking GPs to come together in larger groups and to take on responsibility for spending the budget of most of their patients' care needs. This budget cannot be used by GPs for personal income, it's for patient services only, and will give GPs further professional and ethical incentive to prevent unnecessary use of hospitals and to care for patients closer to home. Another important part of our system is the way we evaluate new medicines and decide whether they can be used in our health system. Our National Institute for Health and Clinical Excellence, or NICE, is an independent body that assesses new medicines for their clinical and cost effectiveness. Once a medicine is approved by NICE, it's made available to be prescribed throughout the NHS. This means we're able to focus our limited resources on the most cost-effective drugs. In addition, the government, through the Department of Health, negotiates the cost of medicines with the pharmaceutical industry, using the huge buying power of the NHS to keep prices down. An important outcome of these two policies is that today medicines account for only 10% of the annual health budget in Great Britain. If we look now at funding, the UK government sets out its spending commitments through a comprehensive spending review in which budgets for all departments are typically set over a 3-year period. The vast majority of budgets... That's right, it's meant to be like that. That's right. The vast majority of budgets for the Department of Health is allocated providing frontline services in the NHS. To ensure clarity on what those commissioning services should be paying, providers have a system called payments by results. Other countries may use terms such as case mix funded systems or prospective payment systems. But the underlying principle is that prices are allocated against specific activity at the beginning of the year. The provider then knows exactly how much they'll be paid for a given procedure. The following slide illustrates the key components of the payment by results system. The foundation is a classification system based on WHO's diagnosis codes and local country procedure codes. Information technology systems work out from these codes the specific currency we use to generically describe that activity and prices allocated against that currency, which we term a healthcare resource group. A standard price or tariff is then calculated, which those commissioning services pay providers. But no healthcare system is perfect. Throughout its history, the NHS has evolved, moving with time and taking advantage of the latest thinking. The challenges I described earlier are driving us to improve the quality of care while maintaining access for all and containing costs. To do this, the NHS is currently undergoing the most significant period of reform in its history. At the centre of our reforms is an ambition for better outcomes for patients in 5 key areas. These are preventing people from dying prematurely, enhancing quality of life for people with long-term conditions, helping people to recover from episodes of ill health or following injury, ensuring that people have a positive experience of care, and treating and caring for people in a safe environment and protecting them from avoidable harm. Our vision for the National Health Service in England is based on 3 core themes. First, the focus is on patients and the public, understanding their healthcare needs and providing services to meet those needs. providing choices rather than telling patients they must get their service at the local hospital using a specific treatment, providing information to help patients make informed choices. Very much one of the sayings we have is no decision about me without me, and providing advocates who work on behalf of patients to force improvement in healthcare. Secondly, our focus is on improving outcomes for patients by developing an outcome framework with relevant expert and patient stakeholders so we know the key performance metrics to collect. Historically, we've collected a lot of metrics around processes in hospitals, but very little on the outcomes of care for patients. By implementing clinical guidelines based on evidence through our internationally renowned NICE, National Institute for Health and Clinical Excellence, and by providing incentives through our payment system to influence hospitals doing the right things for the right reasons. Thirdly, we have a system that provides more autonomy and independence for professionals and organisations, with more accountability to patients. Our hospitals are not judged on how they treat their patients, but solely on outcomes, quality and patient experience. We have focused on improving efficiency and reducing the burden of bureaucracy and data collecting to ensure that every pound spent provides the greatest value and the best healthcare outcomes. To achieve these outcomes, we are making changes to our system. Starting from next year, our reform programme will implement changes designed to place more power in the hands of local doctors to control local services. We're also taking steps to put more power in the hands of patients to choose how and where they are treated. On the provider side, we want to see more diversity and better governance. While it has always been true that the NHS has comprised a mix of providers, both public and private, most are state-owned. The reform programme will allow for new entrants and new forms of provider, where they can offer sustained improvement in patient services. We also want to see greater transparency about performance, so that healthcare providers can benchmark how they are doing, and so that the public can see how well their local hospital is doing. And we're strengthening regulation of providers, so that when failure happens, hopefully it's very rare, but when it happens, it can be managed so as to protect the patient services. In terms of payments and incentives, our focus is to achieve the highest quality of care for the best value. We do not believe in competition based on price, but we do believe that financial constraints have to be respected, and therefore we look to reform and innovation to help maintain and improve quality. And above all, we are working to move more care out of hospitals into communities. Why? Because the evidence we have suggests that people prefer to be treated closer to home. And new technologies such as telemedicine, telehealth, and remote monitoring now makes it possible to deliver more care cost effectively in people's own homes and in local clinics. This slide gives an overview of the health system in England from April next year. The Department of Health allocates most of its money direct to the NHS Commissioning Board that oversees the commissioning process. It also sets objectives for the Commissioning Board. The Commissioning Board hosts clinical networks that cover individual disease or client groups, and clinical senates. These cover the different health economy areas across the country. The Commissioning Board allocates funding to primary care-led commissioning groups, but they also commission some services, clinical commissioning groups commission most services from local hospitals or providers, while the Commissioning Board commissions more specialist services. The providers are regulated on a consistent basis by the Care Quality Commission. This organisation focuses on the quality of care provided. They're also regulated by Monitor, the economic regulator that focuses on promoting value for money. Meanwhile, local authorities have a new role shaping NHS commissioning with strengthened proposals for health and well-being. for health and wellbeing boards. Local authorities also feed into public health service, promoting health improvement in their local population. Public Health England is a new organisation that will be established next year, which will be a separate organisation with a specific remit around improving public health to prevent people from having to enter the healthcare system in the first place. Then there is adult social care to protect the vulnerable and the poor and ensure they're able to access health services. Finally, Health Watch provides a national and local advocacy role for patients. The Department of Health itself provides strategic coordination at a national level. It's not the role of ministers to run the health service, although the Secretary of State remains accountable overall and has powers to intervene in the event of significant failure. In conclusion, over the past few months, I've seen for myself the scale of the task you have ahead of you in rebuilding your health system. With the world's largest integrated health system, I believe that the UK has a lot to offer as you move to rebuild your health system. We have world-leading expertise in planning and delivery of health systems and across a wide range of clinical disciplines. Our commercial healthcare sector is able to deliver state-of-the-art healthcare facilities, products and services. We have world-class universities with an outstanding record of research, and we're proud to educate many student doctors and nurses from all over the world. And we have experience of managing change and improving our system over many decades. Many of you will have seen the opening ceremony from the Olympic Games last month, including an entire section dedicated to our National Health Service. This caused much debate amongst visiting commentators at the time. In Britain, we're in no doubt about the value of the NHS, and while we can always see scope for improvement, we remain proud of what the service achieves on a daily basis. I believe in the spirit of partnership, we have many lessons from our experience to share with you. And at the same time, we don't claim to have a monopoly on good practice, on good ideas. I'm sure as you move to rebuild your health system, there'll be much that we can learn from you. So I very much look forward to the rest of this conference and the conclusions that you draw at the end of this. Thank you.
Okay, thank you, Nick. We're running behind time, so we've got time for a couple of questions. I've already got 3 hands up in the middle there, so can we get a mic over to the middle, please?
Thank you for this lecture. My question is, how much you pay for a GB, and how long does it take you to qualify a GB? And the third question is about a GB. The proportion of GB to population served by this GB.
Okay, I'm not sure I've got any particularly specific answers to you, because the amount that gets paid to GPs varies from practice to practice. I think typically it's in the order of about £100,000 a year as an average, but there is a lot of variation in the system there. And similarly, in terms of practice size, that again very much varies depending on where the GP is as well. But it's somewhere in the order of 20,000, 30,000 patients per practice.
About we have introduced this recently, and many people who work in hospital is shifted down to do the GB. So I'm asking, is it interesting to do is GB with special interests, since they have GB working in pediatric first, and they will be provide the service as a special interest, or dermatologist and blah, 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 or you prefer to be the GB run that general service?
Again, you see variation across the UK, but increasingly we're seeing groups of GPs coming together, some with a specialism in one area, but they do provide a service across the whole spectrum for patients.
There's okay, and there's the last question in the middle on this side.
Thank you very much for the fantastic overview for the NHS service in the UK. I would like to take you back in the history of the established or the start of the NHS. It sounds like it's a GB-based service is a key thing to have. So when the NHS started after the Second World War, was the GB service there and integrated, or if we want to adapt a similar model in Libya, where we could start, please?
I have the disadvantage of not having been around at the time the NHS was established, but looking at today's situation and comparing our situation with other countries, it's clear to me that having a primary care system at the heart of your health system helps manage resources through the whole health system.
There's one final question.
Yes, thanks. I have two questions. The first question is, many people distinguish between primary care and primary health care. So do you all agree, people from other different countries, and does this have any consequences on the organization of health services in the country itself? The second question, you recommended the UK system, and I think that one of the reasons of this conference is to trying to make a pathway, what are we going to choose? And for many reasons, I think many people, including Dr. Reda himself, would prefer the UK system. But in the international benchmarking of the WHO in the year 2000, and again in the European Health Consumer Index for the last 5 years, all Beveragian style health systems were always ranked low. And it was not, had never been the first. In the international, that was the French healthcare system, and the European, the last 3 years, it was the Netherlands. So is it that you don't agree with the criteria that is used for this classification, or you have another opinion? Thanks.
Make one point to start with. It may have been unclear from my presentation, but I wasn't recommending one system or another. I was simply describing how our system works in the UK. In terms of primary care, as I illustrated, our system is changing. We're moving towards a more integrated system with more emphasis on care at the local level, and so the range of services through primary care is changing. It's interesting, go back to one of the slides from the Finnish model where we're looking at comparison between Beveridge and Bismarckian systems. One of the factors that separated out the Bismarckian system was a clear separation between funder and provider. Actually, if you now look at the way we're moving our system in the UK, it again will have a very clear separation between those that commission services on the one hand and those that provide services on the other. So the distinction between the two is increasingly becoming blurred.
Okay, thank you. I think the reliable indicator that we look at is general public satisfaction or otherwise in the NHS, and invariably the NHS scores very highly, and if there's any tamper with the NHS, the government comes under a lot of scrutiny and pressure to actually make sure that any changes are for the best. So, you know, sort of, as Nick said earlier, whilst the NHS has got room for improvement, quite a bit of room for improvement, I think generally the quality of healthcare, given the underlying patient population and the culture of the country, which I wouldn't say is as conducive to good healthcare as Scandinavia or Japan or other countries like that, I think generally we do fairly well. Okay, thank you.
Okay, thank you very much. Thank you for the presentation. Thank you for the questions. The idea of this session is indeed to present to you different that are present in the world. We are not trying to recommend any model. It was stated very clearly this morning in the presentation made by Dr. Erhola that each country has to have its own system that is suitable for its own culture, for its own history in the way that health system has developed. I have the pleasure now to introduce to you our next presenter. This will be Dr. Rida Al-Oukali. Dr. Rida Al-Oukali is Libya representative at WHO in Geneva. He is a graduate from the Faculty of Medicine in Benghazi. He has then earned his fellowship from the Royal College of Surgeons in Edinburgh, and then he has got a degree in cardiac surgery from Manchester. He has worked as an assistant professor at the National University of Singapore, and he has a subspecialty in cardiac surgery. Dr. Al-Oukali has published a lot. He has more than 70 academic papers. He has tried to establish a program of cardiac surgery in Benghazi, during the time of the previous regime, which he has failed to succeed in, and now he's working on this again. His area of interest revolves around health system research, healthcare financing, and health diplomacy. Dr. Al-Oukali, the floor is yours. You have 20 minutes, please, to dwell on the Singapore model. Thank you.
Mr. Chairman, ladies and gentlemen, I will talk in Arabic, then we will probably summarize in English. تمويل خدمات الصحة المثل السنغافوري. السؤال الذي يدور في خلد الجميع هو في ليبيا: إذا كان لدينا هذا الكم من الموارد المالية في ليبيا، فلماذا لا تكون لدينا خدمات صحية أحسن مما هي عليه الآن؟ الحلول كثيرة، وهذه الشريحة تورينا طفل من المدرسة يقول لأبوه: كان عندي مشكلة بسيطة اليوم في المدرسة، لكن الحمد لله حليتها، وهذا البلجيكي متاعك. مسدس. هل يمكن أن تحل المشاكل الصحية بالمال فقط؟ لو أخذنا أمريكا على سبيل المثال، فهي تنفق 600 مليار و82 على الخدمات الصحية كل سنة، وهذا يفوق ميزانية وزارة الدفاع الأمريكية. أو بمعنى آخر، أمريكا تنفق ما يعادل $7,000 للمواطن الأمريكي كل سنة. لو نظرنا إلى مثلا معظم الدول الأوروبية، فرنسا، فمعدل الصرف عندهم حوالي 4000 أو 3 إلى 4000 لكل مواطن في السنة. ليبيا الأرقام مفبركة، في الواقع هي حوالي $240 في السنة على المواطن. بطريقة ثانية، أمريكا تصرف 17% من الدخل القومي، فرنسا 11% من الدخل القومي، وسنغافورة فقط 400 من الدخل القومي. وإذا نظرت إلى متوسط حياة المواطن، تجد أن سنغافورة وفرنسا متقاربتين جدا، وأن أمريكا بالرغم من الأموال الفائقة التي تنفق، متوسط حياة المواطن أقل بحوالي 2 أو 3 سنوات. وهذا يعكس سوء الخدمات الصحية في أمريكا إلى حد ما، بالرغم من تقدم التقنية والخدمات في داخل المستشفيات اللي تعتبر من أحسن دول العالم في هذا المجال. منظمة الصحة العالمية صنفت فرنسا الأولى في العالم، وسنغافورة رقم 6، وأمريكا تعتبر رقم 37. ليبيا هنا مش باينة، هي رقم 87. فإذا كانت ليبيا تصرف حوالي $240 على المواطن الليبي كل سنة، وأن متوسط حياة الإنسان في ليبيا أقل من 70 أو حوالي 72 سنة، فهل لو أن نظرنا في تكلفة علاج الصحة أو المرضى والجرحى الليبيين في العام 2012، سترى أن في الواقع أن ليبيا صرفت مبالغ مهولة، ومنها ما أهدر خارج البلاد وداخل البلاد على علاج الجرحى والمرضى. تكلفة الصحة غالية، هذا شيء متعارف عليه. الأدوية والمعدات مكلفة، رواتب العاملين مكلفة، بالذات لو أعطيتهم حقهم. الإدارة مكلفة، أمريكا تنفق 30% من مصاريف الصحة على الإدارة فقط، بالإضافة إلى زيادة في عدد السكان. كما أوضح بروفيسور روزلينغ، لو نظرنا إلى تعداد السكان في سنغافورة في عام 80 كان معظمهم تحت ال50 سنة، لكن في عام 2020 عدد الناس الكبار حيزيد. كلما تقدم العمر، وهذا حيصير في ليبيا في خلال السنوات القادمة إن شاء الله، كل ما تقدم عمر الإنسان كل ما زاد عدد مرات دخوله للمستشفى، وكل ما زادت تكلفة دخول تكلفة كل حالة أو كل مرة يدخل فيها المستشفى. فكيف تتحكم سنغافورة في تكلفة العلاج؟ كيف أن سنغافورة تصرف حوالي 10% من قيمة ما تصرفه أمريكا؟ القيمة هذه بالدولار السنغافوري ما يعادل حوالي 800 دولار أمريكي، أو حوالي 10% من تكلفة العلاج في أمريكا، ولكنها لديها من الخدمات الصحية ما يؤهلها أنها تكون تضاهي أوروبا وأمريكا، بل يعني حتى تفوق أمريكا في بعض الأحيان. الحل هو أن التأمين الصحي الملزم. سنغافورة تأخذ في حوالي 7 أو 9% من دخل كل مواطن كتاكسيشن من أجل خدمات الصحة. ليبيا دولة غنية، ما فيش داعي أن نأخذ الفلوس من المواطن. الحكومة تلزم أن تدفع هذا المبلغ في حساب خاص للمواطن نفسه، ويستخدم هذا الحساب فقط زي ما أشار بروفيسور روزلينغ في اتجاه واحد، هو استخدام أو دفع لتكلفة علاج المريض. سنغافورة وضعت حوالي 50 مليار في هذا الحساب أو الحساب التأمين الصحي الملزم، وهو ما يكفي حوالي دخول أي مواطن 9 مرات على نوع الخدمات سموه كلاس بي، أو 10 مرات على كلاس سي. ولو نظرت في الزائد أو الفائض المالي في سنغافورة في حساب الصحة بالذات تراه في تزايد كل سنة. تقريبا الدولة الوحيدة في العالم اللي لديها فائض لما تتكلم عن تكلفة أو مثلا ميزانية الصحة. طبعا سنغافورة اكتشفت هذا عن طريق شيء اسمه التأثيرات المعنوية أو مورال هازارد. حاول روزلينغ أمس يشرحها، لكن للأسف كان مشاكل التكنولوجي لم تسمح له بذلك. هذه من الأساسيات الاقتصاد. المشكلة المورال هازارد أو التأثيرات المعنوية تنتج حينما يتكفل أحدنا بالقرار والآخر يدفع الثمن، وهذا قد يؤدي إلى سوء استخدام الموارد أو الخدمات. على سبيل المثال، إذا عندك سيارة عليها تأمين شامل ودخلت للبيت، وأول ما دخلت شعرت مش متأكد هل أنت قفلت السيارة ولا لا، لو عندك تأمين شامل عارف أن لو ضاعت السيارة ثاني يوم حجيب لك نفس السيارة أو يدفع لك قيمتها بالكامل، مش حتطلع من البيت، أو معظم الناس مش حيطلعوا من البيت عشان يتأكدوا أن فعلا السيارة مقفلة. لكن لو ما عندكش تأمين شامل، أو لو عندك أنت مثلا في شيء في بوليس التأمين بتاعك تقول لك أنت لو ضاعت السيارة حتدفع أنت قيمة من ثمن السيارة، والشركة حتدفع القيمة الثانية، حتطلع أنا متأكد حتطلع من البيت عشان تطمئن إن سيارتك فعلا من مقفلة. هذا هو المورال هازارد في خدمات المالية بالنسبة للتأمين. لو طبقنا هذا في الصحة ترى أن المريض عنده سوء استخدام الخدمات في قطاع الصحة. عدم الاهتمام بالمواعيد، كم مرة مريض ليبي يجيك في موعده، كم مرة تحجز له موعد العملية، وكم منهم ممكن يلغي العملية بسهولة مثلا حتى ما يتصلش بيه يقول لك أن العملية تم، أنا عندي ظروف مش حنجيك. شوف عدد الزيارات للعيادات والمستشفيات، وكمية الأدوية التي يأخذها ممكن في اليوم ولا في الأسبوع، وممكن عادة ما يستعملها شيء يرميها في الزبالة. هذا هو سوء الاستعمال الخدمات أو مورال هازارد أو التأثيرات المعنوية اللي يجب علينا أن نمنحها في قطاع الصحة في ليبيا إذا كان نطمح إلى التقدم في هذا القطاع. الطبيب نفس الشيء، أسهل شيء أنك أنت جالس في مكتبك تقول له والله علاجك مش متوفر عندي، أنت أطلع برا العلاج. تكلفة المواطن الليبي المريض الكرونيك ديزيز تفوق 100,000 جنيه ليبي كل مرة يطلع علاج الأردن أو تركيا واليونان. الأرقام هذه حقيقية من أحد اللجان العلاج. يعني أقل أدنى تقديره 75,000 جنيه ليبي لكل مواطن يطلع لتركيا أو اليونان للعلاج. هذه moral hazard on behalf أو مثلا يعني هذه بسبب الطبيب. كذلك المستشفى، في مستشفياتنا أنت لو أهملت الخدمات السريرية والتشخيصية مش حيجيك المريض، يعتبر من نوع من سوء استخدام الخدمة. كيف نتحكم في هالشيء من قبل المستشفى؟ طبعا هذا شيء معروف اسمه DRG، أنه هو يضع سقف لعلاج كل حالة. مثلا إذا كان عندك مريض يحتاج عملية زرع شرايين تاجية مثلا، بيكون قيمتها ما يزيدش عن 10,000 جنيه ليبي في معظم دول العالم. فمهما كان الحالة، مهما طالت أو قصرت الحالة، بيكون في سقف. الطبيب والمستشفى مش هتستغل الظرف وتزيد مثلا قيمة تكلفة علاج المريض في ذلك اليوم. لما يكون أنت دكتور عندك DRG مثلا لحالات الكحة، أو المريض اللي عنده احتمال يكون عنده مشكلة في صدره، عندك DRG ثابت مثلا لما في العيادة قيمتها 1000 جنيه، لما يجيك المريض هتعمل له أشعة وتعمل له سبيوتم سيتولوجي وتطمئن إنه ما عندهاش CA لانج، ممكن عادة حترضى إنه يروح. لكن لو الطريق مفتوحة وعندك أنت تقول طبعا نبي نطمئن، ما نبيش يجيني بعد 5 سنوات حتى لو كان ما عندهاش الآن، بس بعد 5 سنين عنده لانج كانسر، فبيستحمل نفسه يقول أنا بدي أعمل له CT سكان. CT سكان حكلفك $1000. CT سكان مش كفاية أو في شك وأنت مش مطمئن، برضه ممكن تعمل له بات سكان حيكلفك $3,000 إلى $4,000 ممكن في الزيارة الواحدة لذلك المريض. هذه كلها عشان تتحكم في هذا سوء استخدام الخدمات من الناحية هذه، وجب علينا أن نضع سقف لتكلفة كل حالة سواء داخل مستشفياتنا العامة أو مستشفياتنا الخاصة. وكذلك بالنسبة للجرحى، لو نظرنا إلى DRG للwound debridement في وجود بعض المشاكل أو الأمراض المزمنة الحالات في ألمانيا ما تزيدش عن 7,000 أو 8,000 يورو. مرضانا أو جرحانا في ألمانيا متوسط تكلفة علاجه 170,000 يورو. هذا سوء استخدام المستشفيات في ألمانيا، فما بالك لو كان في داخل ليبيا. ولو تحكمنا في هالشيء ومثلا كان تم كما تقول assessment أو تقييم حالة كل جريح أو كل مريض يحتاج علاج مش متوفر في ليبيا، وتم إيداع هذه القيمة في حساب ذلك المريض، له الحق في التصرف فيها للعلاج في الداخل أو خارج ليبيا، ولكن فقط لتكلفة الصحة. ما أعتقدش كنا حنهدر الأموال التي تم إهدارها. ما أعتقدش أن حيكون في جريح ليبي جالس في مصر في فندق 7 نجوم لمدة 6 شهور ب$140 في الليلة من أجل علاج طبيعي. اوكي، هذا اللي زي ما اتفقنا، هذه اشرنا لها السلايد، انه مهم جدا ان الحكومه الليبيه تفكر في تمويل خدمات الصحه بطريقه تمنع سوء استخدام الخدمات من قبل المريض، من قبل المستشفى او من قبل الطبيب. وللمريض او المواطن الحق انه يشتري مثلا تامين من داخل ذلك الحساب. ممكن يشتري تامين اللي هو المتعارف عليه تامين صحي مثلا في شركه خاصه لعلاجه في داخل ليبيا او خارج ليبيا. ممكن ياخذ القيمه من ذلك الحساب الملزم لشراء تامين صحي شامل مثلا او اكثر، او ممكن بخدمات خاصه يحتاجها هو المريض. النظام الصحي في سنغافوره يجمع عده انظمه. بالنسبه للنظام الصحي، نظام تمويل الصحه في سنغافوره يجمع عده انظمه فيها بريطانيا، وهو منها التاكس بيزد. طبعا هذا CPF ولا التامين الصحي الملزم في سنغافوره، هذا يعتبر خاص بسنغافوره بالدرجه الاولى. على فكره انا اشتغلت في بريطانيا 11 سنه وفي سنغافوره 11 سنه، واليوم لو اخترت نظام تمويل صحي لاي دوله في العالم، انا حنرجح سنغافوره فوق اي دوله ثانيه. حنعطيكم السبب ليش. هذه احدى المقالات المنشوره في احدى المجلات الامريكيه اسمها The American، والذي يقول فيها الناس الدولة المدينة سنغافورة قد يكون لديها الحل لمشاكل خدمات الصحة في أمريكا. لكن كيف أخفق أمريكا؟ حاولت، وبعض الدول فرنسا وممكن بعض الدول الأوروبية حاولت تطبيق هذا النظام في تمويل حسب خدماتهم الصحية، ولكنهم أخفقوا في حالة واحدة، أنهم هذه الأموال التي تم مثلا وضعها أو إيداعها في حساب لخدمات الصحة، سمحوا لها بإدارتها من قبل شركات تأمين خاصة. هذه المشكلة الأساسية، لأن شركات التأمين الخاصة بيدفع أي رواتب وقيمة التكلفة عنده في الإدارة، يعني ما لهش رقيب ممكن يدفع لنفسه عدة مليونات كراتب، هو مثلا السي او كمدير لشركة التأمين. لكن سنغافورة طبعا الأموال التي توضع في التأمين الصحي الملزم في سنغافورة تدار من قبل جهة حكومية تابعة لوزارة الصحة مثلا أو تابعة للحكومة السنغافورية. فبالتالي لو ترى تكلفة التأمين الصحي لعائلة في أمريكا في عام 2000 هنا كان حوالي $6000. في عام 2012 تضاعفت القيمة إلى حوالي $12000 بسبب أن التحكم أو مثلا المانجمنت أو إدارة الأموال في التأمين الصحي الملزم في هذه كان يدار من قبل شركة خاصة. بالليبي لا يوجد لدينا ما يسمى بالخدمات الصحية المجانية. في حد منا حيدفع في النهاية، يا أما أنت كمواطن حتدفع من التاكس من جيبك، أو أنت كمواطن ليبي حتدفع من موارد الخاصة بك اللي هي البترول الليبي. لا يوجد شيء اسمه خدمات صحية مجانية. والأسوأ من هذا الانطباع المجانية يؤدي إلى سوء استخدام الموارد من قبل الطبيب، من قبل المريض، ومن قبل المستشفى. نحن في حاجة ماسة للتحكم في سوء استخدام الموارد من قبل المريض، وذلك بالتأمين الصحي الملزم، ومن قبل الطبيب والمرافق الصحي، وذلك بتحديد سقف لتكلفة كل حالة مرضية. ولكم الشكر.
Thank you.
If I have time, I can go through the English summary of the whole thing.
I think I got the gist of it based on reading the slides, so I think that's fine, and thank you.
Maybe in that discussion there will be a few questions in English as well. Thank you indeed, Dr. Al-Awqali. I like the conclusion that Dr. Al-Awqali has arrived to, where he said that he recommends the Singaporean health system. And if we looked at the slide that he showed that system is a mixed system, where there's a combination between the Beveridgean system and the Bismarckian system and other models. And this is where most of the countries are going now, where the details, indeed, as we say in English, the devil is in the details. It is in the way that you are implementing that system. It is in the way that you are looking at collecting the resources, managing them, and using them for purchasing the healthcare services. We have few minutes for a few questions, so please, the floor is open. Yes, please. Can you use the mic?
السلام عليكم. شكرا دكتور رضا على المحاضرة. Okay. I'd like to ask about the pharmaceutical industry or pharmaceutical factory. We need how we can make pharmaceutical industry and how we can finance this project.
Thank you. There will be a whole session on pharmaceuticals. Maybe I think we can discuss that in details during the time. We're trying to focus on the finance in this session, particularly financing health as a system in general, not particular aspect of it. Maybe we will be able to, you will be discussing this in your session on pharmaceutical, Dr. Muhammad.
Okay.
Thanks, Dr. Oakley. I would like to ask, what happens if someone hasn't used his budget for a while? Like, for example, if myself, I haven't been in the hospital for a few years, would be able to use that account for my own?
No, that budget, that money will be available for the لك كمواطن أو للعائلة بتاعك، واخد بالك؟ لكن فقط من أجل خدمات صحة، مش لأي شيء ثاني. مش هتقدر تشتري بيه حوش.
But for example, for 10 years.
إن شاء الله حتى 100 سنة.
I think it's good to see an empowerment of patient to get control of the budget. But if, for example, the budget hasn't been used, there should be kind of, an incentive for the public to use that money.
هذه حتورث لأبنائك إن شاء الله وأحفادك، فحيكون عندهم ضمان
شكراً.
خدمات صحية ومستقبل.
Thank you.
Thank you. We will take a couple of more questions. Please, if you can make them brief.
السلام عليكم.
عليك السلام.
محمد المرابط من الزاوية بس been working in Canada. I see that we are kind of trying to find out our path, which system will work for us, but we have to understand that we as a Libyan society have our own particular things which are different from the British system or the people in Singapore. And I understand that we in Libya is a rich country, but we have to take responsibility in the healthcare system. So I am not really very supportive of the idea that the citizen should not pay toward healthcare. I think every citizen should pay toward healthcare to realize that healthcare costs. But if it's free, if the government pays for it, there will be misuse of health services in the country, and there will be misuse by physicians as well as by patients alike. So I like the Singapore model with some modification that the citizen should pay that 10%. Those who are unable, those who are on social welfare, the government will take care of that. But anyone who is able to pay, you should pay your share toward it. Thank you.
ممكن تعلمنا في الهيلث دبلوماسي ان نكون شوي دبلوماسيين. ممكن نوافق ان الحكومه تدفع قيمه الاكبر والمواطن يدفع حوالي 2-3% من راتبه من اجل تمويل خدمات صحيه. ممكن هذا يكون حل مناسب. نعم.
Well, I'm really sorry. There are too many hands, too many questions. Very interesting, but you should know that tomorrow there will be, and after tomorrow, for the coming 3 days, there will be dedicated sessions for each of the building blocks of the health system. We will have 4 hours to discuss the health financing for the case of Libya, and we will go into all these details. But I'll give the floor to Dr. Samir bin Yahma, and this will be the last question or remark from our side. Thank you.
Yeah, I want just to make a comment because we have heard this repeatedly during the conference that Libya is a rich country and therefore Libya should pay. We have to be careful that if we think that there is that big amount of money and it needs to be paid, what will happen is the health sector will be some sort of a pit with no bottom, where you will throw money but you will not see it. No country can afford something that will be for free for everybody, and you said it yourself, that people will keep going everywhere in order to gain treatment and ask the country to pay. So we need to have, I very much agree with the last speaker, we need definitely to facilitate the life of the citizen, but we need to make the citizen accountable for what they are going to consume from the system. We have indeed several sessions about that, but I wanted just to make that observation so that we don't think that the country is rich. It will become such a burden on the country that it will be not affordable on the long run.
There is a burning remark from my director, so I have to give him the floor. Dr. Siddiqui.
I think it's important that before we embark on a strategy for health financing in Libya, we need to have more evidence. And I think there are 3 areas where we need to work intensively with your colleagues here. I think the first is to have what we call a national health accounts analysis, which I think is absolutely essential. The second, I think we should need to look if we can get into a household health expenditure survey, which is absolutely essential, and it's essential for the health accounts analysis. And then we also need to look at how the health system from a financial perspective has been organized in Libya. I think we need that evidence, and we should, while it's important to have a strategy, but we should not hurry into a strategy next week or next month, because I think it's a critical strategy which will drive the sector over the next coming 10, 20 years. So evidence before we get into a strategy, I think is absolutely critical. And as WHO, we help countries, and we'll be very pleased to work with you in these areas to come up with more evidence, to come up with a real strategy for the health financing system in Libya.
Thank you indeed, Dr. Siddiqui, and I don't think that we can conclude with a better remark than this one. Evidence, 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 in order to build our future, the best health system for Libya and for the best of the Libyan nation. Thank you very much. We will cut short the break. Instead of having half an hour, let us break for 20 minutes.
We will reconvene here at 11:30 to proceed with our program. Thank you very much.
As we heard on the first day, is to provide better services, better outcomes. And Professor Michael Porter, who many of you know from Harvard Business School, has talked about value in healthcare being quality or outcome over cost. And we've done an awful lot over many years to measure cost. We have huge systems to define the costs and how much is being spending, and we collect all the data, but we have rather less good systems in collecting the upper part of that equation, the quality or the outcome. And I think that is what this session today is particularly about, health information, collecting data, which helps us understand clinical metrics and clinical outcomes. We have two speakers, Mike Sexton, who is the Chief Financial Officer and Director of International Affairs at the Universities of Hospitals of Birmingham in England. Wonderful new hospital, the Queen Elizabeth Hospital there, who have really established an international reputation for their healthcare system, health information system. And then Mr. Ali Bahran, Head of Clinical Systems Development at the Heart of England Hospital, also in England, who has 20 years of experience in IT and health informatics. So, Mike, if you want to start.
Okay, thank you. Can you hear me?
Yeah. Yes.
Okay, great. Well, the topic of why have healthcare information systems is really broad and too broad to actually give it justice in 20 minutes. So what I've had to do is actually narrow it down to a few specific areas of particular interest to University Hospital Birmingham. I say University Hospital Birmingham perspective because some of what I say might not necessarily sort of accord with what the NHS is doing across the country. I think it's fair to say that we rock the boat quite a lot at national level in terms of what the Department of Health should be doing in terms of information collection, particularly on a quality basis. I think there's a lot of what you don't know doesn't hurt, and our philosophy is completely different to that. We want total transparency and openness, and I think that's the only way you can actually manage effectively in an organisation. I think whilst it's fair to say our focus has been on quality and patient care, there are significant benefits in terms of efficiency and value for money that can be derived on the back of actually getting things right the first time. We've self-financed everything we've done in our hospital ourselves. We've got a new PFI scheme, and those of you who are familiar with the NHS know that most hospitals have got large PFIs struggle financially because they cost a lot to run. At the moment, we're not struggling financially, and the reason we believe we're doing that is because we don't get things right all the time, every time, but we try and minimise our errors, and I'll come on to some of that in a minute. There's a bit of context in terms of the organisation. I won't go through it in detail because we haven't got time, but the point at the bottom about providing informatics for regulators and many NHS organisations is important. We do work with the Care Quality Commission that has been mentioned previously and Monitor. And also, importantly, we actually provide hands-on and strategic support to the National Information Centre, who are responsible for actually providing informatics support to the Department of Health and the NHS. Why have they asked us to support them? It's basically because the building blocks we've put in place, the software we use is much more powerful than the systems that the Department of Health have got. We've used leading edge commercial software on which to base our intelligence, and that's actually put us ahead of the game. So if a minister asks for some information, and it's quite a complex question, quite invariably the National Information Centre will come to us to ask for the answer because they know we can turn it round in an hour when it's going to take them 3 days, and that's not sort of overestimating the differential. I won't dwell on that. We've been asked to help support a number of countries in terms of the role of a regulator and the use of information to actually support regulation in the healthcare system. And again, I haven't got time to concentrate on that, but again, what this shows is it's a very, very complex issue to actually get your heads around. And the information has got to come from a variety of different sources, both manual and electronically, in order to build up a reasonably good picture of what's going on in a health service within a country. But what this sort of tries to portray is that over time, we should be trying to move away from a regulatory environment based on inspection to one that's based on intelligence, and intelligence underpinned by high quality data. In terms of the trust, this sort of gives you an example why it's very difficult to actually spend much time in each of the areas. We've got a number of systems in the organisation that actually work together. The key thing is we've got a unified and relational systems warehouse on which to actually drive our intelligence capability. One message I'd like to give to you is there's lots of organisations, commercial organisations out there with systems that help in primary care and secondary care and other aspects of health. It's vitally important that you don't lock yourself into one provider. What you often find is that you buy a system that's very good at doing one thing, but then when you try and extract the data to actually relate the data that's coming from that system to another system, then it's very difficult or impossible to do that. And that's because commercially organisations are incentivised to lock you out. If you're locked out, you're at their mercy, and they either won't let you have access to the data or they'll charge you a lot of money to actually get access to the data. In terms of clinical quality management at the Trust, the key thing is everyone knows there are important errors where there's a direct link to death and you go through the judicial system. Those errors are sort of so catastrophic that you don't need sophisticated systems to identify they've happened. Where organisations struggle is with unimportant errors and the link to death. Our philosophy is that large complex organisations have lots of unimportant errors actually taking place in their organisation on a daily basis that have some relationship to the outcomes of patients, potentially resulting in death. Trying to make the links between those unimportant errors and deaths is impossible. But what we do know is that if you can cut down on the number of unimportant errors, then the number of deaths and the mortality and morbidity of patients actually improve in the organisation. One area we've particularly focused on is drug errors, and it's the most common error in healthcare. 120,000 reported, I stress the word reported, incidents to the National Patient Safety Agency in the NHS per year. Approximately 80% of those are in hospital, and they relate to errors of admission where drugs are not prescribed or not administered, or errors of commission when the wrong drug has been prescribed or administered. High profile issue, lots of coverage in the media at national level in terms of problems regarding drug prescriptions. The traditional approach, measure what is easy to measure, not what is important. Use historical data, which is out of date, open to contest and disagreement. Classic example of the traditional approach is a recent report that came out from these eminent institutions regarding how hospital trusts should actually have effective drug prescribing and reporting regimes in the organisation. And they talk about having good quality paper to actually record the data that doesn't tear or damage during normal use. They also talked about using different coloured pens to describe different actions. We think that's a totally outdated approach. And if there were, maybe in the interim as organisations actually gear up, it's something to think about. But in terms of a long-term strategic approach to actually drug protocols and prescriptions, they're missing the point. What we've done is actually introduce a clinical decision support system that prevents errors at the point of decision. and it provides a clear audit trail for management and doctors, and it manages all patients. Our doctors and nurses are dependent on the system because they can't actually treat patients without using it. The system has actually been developed over a period of 10 years, and it's been developed in collaboration with our doctors and nurses to actually support them. And the good thing about it is it actually does help them. It's not just an administrative burden on them. It actually does help them in terms of healthcare delivery, in terms of managing patients. There's prescribing functionality, drug administration functionality. There's also coordinated with lab results and imaging requests, and also therapy referrals. And nurses actually have to record their patient observations on the system as well. So it's a comprehensive database of activity within the organisation. The benefits, basically, it's reducing risk in the organisation. I'll come on to some of the evidence about that. It's accessible to all people in the organisation. It's effective and fast. There's simple rules, and there's also complex rules in there to actually support doctors and nurses in most difficult prescribing. It was our nephrologists who first asked us to develop a system to support them, and that was because we've got a very large renal program, and the actual drug prescribing in nephrology is quite complex, and they wanted a system to support us. That was 12, 14 years ago, and the system's developed significantly since then. There's the power of real-time decision support because the support's at the bedside. And it provides a clear audit trail, and I'll come on to how we use that. Before we had the system, we did an audit in our critical care unit, which was about 13 years ago now. And you'll see the results here in terms of the paper charts for fluids, drugs and infusions. In terms of lots not being in the bed space, 17% being ineligible to the independent eye, 20%, 28% didn't comply with our legislation in terms of how drug charts should be written up. We identified 3.5% of potential significant errors as well. In terms of the system, we got over 4,000 users. We used handheld tablets and mobile computers and desktops. We prescribe over 25,000 prescriptions per week, and there's 120,000 administrations, so it's a large, complex system. We, based on our research, we believe over 140,000 potential errors are prevented by the system per annum, and we got some evidence to support that. And it actually helps prevent significant variation between junior doctors and nurses. What we found is that with rotations of junior doctors, or when we start to heavily rely on agency staff, we find that their practice isn't in keeping with the best standards that we actually ask our staff to adhere to. By having this decision support system, we can pick up variation in practice very quickly and actually sort of identify the individuals to give them extra training to make sure they start to become compliant. What we can do here is actually identify missed doses this is just a snapshot of the information that's available to us to give you a feel. So we can identify missed doses by a consultant. We can identify also missed doses by ward, so we can identify areas that are outliers, so we can actually look at hotspots in the organisation. And what sits on top of the system we've got are dashboards that actually each ward manager can look at on a regular basis. They're updated at midnight every night, so they're as real time as you can make them, and they cover a lot of different areas, including medicine management. And within there, we've got a number of sub-dashboards. So for medicines management, we've got 8 indicators of performance where they can actually compare themselves in terms of the trust overall and in terms of trend, whether they're improving or deteriorating. And we actually use that information to actually effectively manage the organisation. So we've got a performance review system that takes place. We have unannounced board visits towards. Our board reports incorporate the data that comes out of our system. We've got various monitoring groups as well. We also have what's called root cause analysis meetings. And this is one. What you won't see, can't see, is up on the whiteboard there will be the system in real time actually drilling down to individual patient. And we'll be going through on the other side of the table, you can see we've got some nurses, we've also got clinicians there as well. On this side of the table is the execs, which includes some clinicians as well. And what we'll be going through is the individual patient journeys, trying to understand why things did or didn't happen to an individual patient. And the beauty is that the teams that come in to talk about individual situations, problems, know that there's full transparency. So if they tell you something, you actually go into the system, have a look to see if that was the case. And now, invariably it is, because people know not to come and try and pull the wool over your face. In terms of external comparators, we identified a couple of other trusts that actually have information, electronic information on drug prescriptions. Now, we had to do a lot of manual extraction to actually come up with this status. But what it showed was that in terms of non-antibiotic emitted doses, the rate was running over 20%. At our trust, the figures come down to it's over 10%, but well short of the other two trusts. Now, you might say that performance isn't good. It needs to get better, and we accept that. We're on a journey ourselves. It's only the last 12 months to 2 years, we're actually getting real good traction from the system and the information that we've got. And that was a deliberate strategy. We didn't want to introduce a system and actually then start to try and manage performance really tightly from day one, because we needed it to bed into as part of the culture of the organisation. And then over time, we've used the power of the system to actually challenge and manage performance.
3 minutes, Warner.
Sorry? Okay. Similar situation with antibiotics, where our prescribing rate or admission rate is probably about half that of the other external comparators, which is good as well. In terms of prescribing behaviour, you can see there post-introduction of controls within the system. You can see there's a reduction in use of particular drugs. This is an example in ITU. In terms of lab tests, the introduction of protocols, you show a significant reduction in demand for lab tests. And in terms of mortality, we've actually plotted our mortality rate against the rest of the NHS, and you can see over a period of 3 years there's been quite a significant reduction in our mortality rates. Antibiotic misdoses as well, you can actually track a step change in performance down to specific actions, that was when we first started to share the information with clinicians and managers. And then when we started those root cause analysis meetings with the clinicians, you can see a further step change in performance. I've got lots of other stuff to talk about. Clearly, I haven't got time to get round to it. What you've probably heard, you're probably thinking this is miles away from what we can do in Libya. I joined the NHS 15 years ago. In my trust, there wasn't anybody actually looking after quality, and we didn't have any systems that actually gave us information that helped us manage quality. It was all down to self-regulation. Clinicians actually choosing which areas they wanted to auditing those areas and telling management they were doing okay, or occasionally if there was something really horrendous, they would hold their hands up because they knew it was going to come out. Now we've got much more transparency, there's much more accountability, and I think in 10 years, not even 15, you can get to the same level that we're at. You need to be brave and you need to take bold decisions in terms of what systems and infrastructure you invest in. And by the way, I'm not advocating a particular system, I'm sort of vendor agnostic. There are systems out there that will help you deliver a lot of this. But it's important that you're brave and you're bold and you actually take the steps. It's also important, though, that you take the journey slowly and actually change the culture of the organisation and bring them along with you. What it does, though, is stop the situation now where clinicians say, you can't manage me because the data isn't good enough, or you can't manage me because we don't believe the data, because they're responsible now themselves. They're accountable for making sure the data that we collect is appropriate and accurate, because they know they're going to be managed against it. That's all I want to say. Thank you.
The plan is, the two talks are pretty complementary, so the plan is that we'll take both talks and then have questions on the session at the end. But as I haven't got the slides up, you're ready to go, Ali. Mike, do you want to take one question while we're just getting the slides sorted out?
Dr. Saxton, very, very informative talk. Thank you. Information is synonymous to intelligence, and intelligence is something that can be abused. What's your experience in this regards, and have there been any developed built-in sets of checks and balances to protect me as a practitioner from the information you've gathered in my performance?
Well, there's total transparency in the organisation as part of the individual clinician appraisal. All the information shared with the clinician for them to actually validate and agree. So there is a two-way process in terms of a doctor and manager relationship. Without that relationship, you can't actually work together. It might sound like we're quite hard-nosed and aggressive in terms of how we actually manage our doctors and nurses in the hospital. I'd say that it's a consensual approach. Our doctors and nurses actually have started to like the way we're managing the organisation, because what it's actually done is actually bring up the standards of everybody, and where people haven't been performing for whatever reason, they've actually chosen to leave or they're being managed out of the organisation. But this is almost the tip, starting to, we've done a lot of work over 10 years to actually get us to that position. We brought people along with us, but the early years, we were very careful how quickly we actually started to engage and sort of manage doctors and nurses. We needed to build their trust in the system to do that.
Thank you very much, Mike. Okay, we'll go straight on to Ali, and then we'll take the questions again at the end.
Is it okay? Thank you very much, Mike. My name is Ali Bahroun. I was born here down the road. The mic. Can you hear me now? Ali, can you hear me now? Thank you. My name is Ali Baroun. I'm the head of clinical system development at Heart of England, UK. I was born in Libya, just around the corner, Bab al-Azziya. Yeah, so I experienced both Gaddafi era and the new revolution. First of all, shukran for getting me over here and to try to present. Wasn't me the presenter, but at last changes, I've been asked to come and present. I hope that you enjoy what I have to say. And I hope to come back and probably build what I experienced in the last 20 years. Computer is just, I started in 1991 after graduated from the UK in computer science. We started at a hospital where there was no computer. There was all just collecting data for financing. The first 1991, they had the GB fund holding, so all the budget, and that's what we did. We didn't do any clinical data at all. Time changed, and we need to be smarter. iPad is a wonderful thing. We all use computer on the daily basis. But unfortunately, in a lot of hospitals in the UK, don't have that luxury. I'm pleased to see Mike here because I didn't know that he's coming. He's from my next door hospital. They put a wonderful system there. I built a system as well from 15 years ago. And one of the area which I'm talking about today is actually about database, national registry. The first national registry started 1991 in the UK in Hammersmith. A lot of it about cardiovascular surgery. There's a lot of, at that time, there was nobody concentrating in clinical outcome at all. It was all just collecting data. So I'm just going to go a bit to the presentation. I've been giving 15 minutes, so I might have to speed it up, and then we'll take some question. What's a clinical registry? That's what I'm going to try to cover, and building a successful registry. Example of hospital registry. I work in a hospital, so I know quite a lot about this. Benefit of a national registry, and hopefully we'll have a question and answer. It's a collection of analytical clinical data for a patient, population, procedure, or disease group to include all consecutive cases. No gaps. We don't need any gap. We need to collect all the data. It could be a local hospital. You could have a local just registry for one hospital, just so you can compare between consultants. Or you could have a central registry where multiple hospitals. You start comparing against other hospitals plus other consultants within other hospitals. Or population-based registry where it's whether treated in the hospital or in community, like diabetes. We want to collect everything about patient. Building a successful registry. You can't build it by just one person. It's required a multiple disciplinary team together to build a system. Funding is really important because actually that can cost a lot of money because it can go for years and years. Some of the registry for like cancer registry have been going for nearly 50 years before even computer, paper. So that will cost. Where the money going to come from? Data collection, who's going to collect the data? And data set. Is it going to be a clerk? Is it you're going to get a clerk to collect your data, or is it clinician collecting the data? We have a problem here. In the UK, every time we have a new initiative, a new computer system or a new data collection, we employ clerk. And then what we do, we send the data to the Department of Health, and the data was wrong. So that's very important to get actually being collected by the clinician themselves. Leadership is very important, leadership. You can't run a registry without a leadership. Clinical leadership. There have to be a clinical leadership. And then in my some slides, I'll explain that. Building a successful registry, just a slide here. The temptation of collecting data is you can't resist it. I sat down with so many clinicians and end up with like 15, 20 pages of collecting data. And then they say, you go and demonstrate it to them and demo the system and said, oh, that's too long. I can't actually collect it, but you ask for it. Stick to the main data. If you have a system, locally use it as much as possible. Don't duplication. We do a lot of duplication. We have a BAS system, patient administration system. We have a national registry. We duplicate the same patient demographic, put in again. So just use one. And make sure that it's been checked by the clinician for completion and any duplication. It's very important. I'm just going to give you two examples. Cancer in the UK, we were in the 1990s, cancer was one of the high priority for the government. We were lacking behind our European in mortality. In 2000, there came a white paper around trying to improve cancer. We want to be the same as the rest of Europe. I'm going to take you through one standard. There's a lot of standard. Obviously, the government pushed a lot of screening. They pushed a lot of money, putting a lot of money into cancer. And I'll take you through one standard, which is waiting time. Waiting time, we were like watching patient coming in, slithering into the system and disappearing. There was no computer system actually we had to monitor. So we were not meeting our target. At that time, 2004, we were like one of the worst in the country. We were only achieving 80% of the target set by the government, which is 14 days from a suspected cancer to be seen at an outpatient clinic, 31 days from diagnosis to treatment, and 62 days from suspected to confirm to treated as well. So the target was a great target because actually cancer, I mean, you can't wait for 15 days. You know, if somebody comes in, okay, oh, I suspect you have cancer, you want to treat it straight away. So we had some target. We wanted to enhance the communication with the multidisciplinary. They were spending so much time. Just for 10 patients, we were spending like a couple of hours discussing patient. And we had a wonderful clinical leadership. She just wanted to make a change. She wanted to make a difference for her patient. She would stay until 7 o'clock the night, every night, to make sure all the data gone through. Created what we did. Created a RAD system, traffic light system, real-time tracking of patient, no patient miss, real-time. Any suspected patient went into the database, we tracked it. And the clinical leader actually can take them off. We saved a lot of time in the MDT, and we improved outcome. This is the system we created. That's the red here. Look at here. We have saved like 16 days. The target is the 31st of August. Actually, we're treating this patient 16 days earlier. I'm just going to skip to this, but that's available to look at. I'm just going to emphasize that's ICD-10 we use. This is the standard, again, for diagnostic area. And what we managed to do in that little short of time, within a couple of years, we were managing to reduce some of the cancer waiting time by half, which is great. We won an award for some of the beacon from the Department of Health. We were presenting everywhere. But that's just what system can do. The next one, quickly, we're going to go for fractionocapema. Fractionocapema is another one where basically we had high mortality. Length of stay costs a lot of money. Hospital stay, we reckon it's about £300 per day. It's probably better to come here, you know, and stay there. Return to home, I'm not sure whether that's applicable here, but actually patient returning home is a problem for us there. Quickly, the national standard, we were talking about clinical governance yesterday. This is a national standard. They come up with 6 national standards. Surgery within 36 hours. Assessed by geriatrician. Care agreed by surgeon and geriatrician. Agreed assessment protocol. Can you see a lot of geriatrician? The surgeon actually have to probably do the procedure, and then the care will transfer to the geriatrician. Currently, we have, for this fractionocapema, we have a geriatrician employed to just look after this. System, again, just purely data, what we collect, like time from A&E, when they arrive to A&E, and we try to see whether it's been consultant involved, geriatrician involved. And I'm just going to skip to this. This is why. Why hip fracture? Can you see this is a European Commission 1998. Hip incident is going up. I think we've got maybe the weather there in the UK or in the Europe, because everybody just falling and, you know, 20% mortality at 1 year. 25% never go home. 80% of elderly women rather die than have hip fracture. Gosh, that's shocking. But we need to look at the whole system. orthopedics, geriatric, and social services. This is our EPR. Mike talked about an IT earlier. What we did is embedded our national registry as part of the daily routine. We didn't just want a registry in its own by itself. Benefit, benchmarking national standard. We talked about the national standard. We want to benchmark the national standard. Performance monitoring, population level analysis, and international comparison. Quickly, this is available everywhere. Just talk about the report which came out from the Fraction of Kafima national report. A system, 130 pages of data analysis, clinically led web system, all 190 hospitals eligible is registered, around 76 of the estimated 70,000 cases, care audited against the 6th standard, and care and outcome of that. So what's happened here? This is all the data. I'm not going to go to this. It's just data collection, over 1 million data. This is really good. This is interesting here. Surgery within 36 hours of admission. Can you see? That's the top, like 20 hospital, and the bottom 10 hospital. The range from 9 to 88%. Themselves, there is scope for improvement. Mortality related to 36 hours, we can reduce it by half just by having patient coming in earlier. We notice in hospital, sometime in the weekend work is actually high mortality. Weekdays is better. But if you don't have fracture in the weekend, because that's, and that's what's happening here. This here, length of stay. Length of stay, look, variation. 16.4 days to some 8, 9. Why? This graph showing mortality at 30 days. Can you see this hospital here? Why they're different from the rest? That's why we want to drill down to find out why the mortality higher. Quickly, cardio-surgical database. This is a well-established database. This is actually the 6 UK audit. Again, similar information. We have 100% National Health Service, analysis of over 400,000 procedure, and we're using cabbage and value long-term survival rate. 10 years, 25 years trend, and that's going to go to just quickly to early warning system. We can use the data for an early warning system. Here, plotting all these clinicians in the whole country, the data, and then we've got these 3 consultants here is high mortality than anybody else. So we can actually start drilling down and looking at what's the issue there. This is a headline. That's what we wanted. Headline of the UK, boost for the UK of our heart surgery performance. The UK is outperforming most of Europe. In the bottom here, a leading heart surgeon said that the decision to collect data on hospital performance had helped cut mortality by 50%. Yes, great. That's great news. That's what the public wants to hear, because at least they get the confidence in the system. Just population level. This is just one example of international comparison, just showing the UK. There was, we're having AAA surgery. We were UK mortality in elective AAA repair more than double the other. So that's just a quick, because we've got the data. We use a tool called Android. Peter Wilson, who was going to come and present that, that's the tool we use. They have well-established organization providing most of the UK and Europe with registry and national registry. I'm not going to go to this. This is probably selling point. The key is we need provide of real world data in activity and outcome, defining learning curve, defining upper age limit for procedure, if any. You might, the data you can have. Assess in complication risk modeling, short and long-term outcome, devise tracking information to debate on risk and benefit, provide informed health consent for patient, international collaborative for exchange of data, rich data source for own clinical research. Registry itself can improve patient outcome.
Time.
Okay, just gonna leave this slide. Can I just talk about this one a little bit, because I did the presentation in Benghazi 3 weeks before the revolution. I left the slides up, and actually, and then afterwards, just saying any improvement is a change. Not every change is an improvement, but we can't improve anything unless we change it. And obviously, they went and had the revolution. I came back into Tripoli in the 23rd. We drove from the UK, delivering some ambulance to Zintan, and we managed to get into Tripoli in the 23rd, and it was a nice experience. Thank you very much. I hope you enjoyed it.
Thank you very much. What we will do now is, first of all, I think we heard two very, very useful presentations, and to see how information can actually influence outcomes. So what I will do is, I think we can now take a few questions from the floor. I can already see a few hands, and I've noted 2. So what we'll take a round of questions, and let's take 3 or 4 for the moment. So I'll start from here, and I'll go on to that side. Please keep your questions brief and to the point, and then we will ask our presenters to respond. So please, I saw a hand there. Can you start? And then we'll go to, I've noted you as well. Please go ahead.